and welcome to this webinar today. My name is Dr. Harsha Kinnear. I will be moderating this event. Just very briefly, welcome to Surgeons for Surgeons. We are a global surgical network of which Dr. Parul Shukla is the main founder and I'm one of the co-founders. If you're not a member of Surgeons for Surgeons, can you please download and install the app either via Apple or Android systems, whichever ones you're on. And also, if you're able to follow us on X, LinkedIn, Facebook, and social media, that would be much appreciated. We are having a webinar on a very important topic today, and we're fortunate to have Professor Saeed Ahmed and Associate Professor Samir Patel from University of Cincinnati College of Medicine. The main topic of discussion today is regarding investigations management of chronic pancreatitis. We firstly would like to welcome Dr. Samir Patel, who's a surgical oncologist who focuses on HPB and complex GI malignancies. Dr. Patel has completed his undergraduate medical school and surgery residency training at Emory University. He has then completed a surgical oncology fellowship at the MD Anderson Cancer Center in Texas, and has been at the University of Cincinnati since completing his training in 2017. He also performs clinical and translational research, and he's going to talk to us today on the anatomy and investigations of chronic pancreatitis, as well as rest of the HPB anatomy. As a bit of housekeeping, we would probably take questions only after both the talks. We will keep an eye out on the questions on the chat. But if you have any questions, we'd like to have them on the chat during the talks, and then we will have the questions at the end. The floor is yours, Samir. Thank you for coming and joining us today.
Perfect. Thank you so much for having me. It's a real privilege and honor to be here and be able to kind of talk about this. And so today, as you mentioned, we'll be talking about really kind of pancreas anatomy as well as kind of preoperative and anatomic planning. It will also kind of translate into hepatobiliary, but the focus will really be kind of pancreas focused today. And so, as everyone's aware, when we think of the pancreas, this is the typical picture that we see, in which we really divide the pancreas into 5 different regions: the head, neck, uncinate process, the body, and the tail. And while this is very important for us surgically, it's also really important to appreciate what it is that our pathologic colleagues think of when they think of those same regions of the pancreas. And so if we look at kind of the newest version of the AJCC, which is the American Joint Commission on Cancer for Pancreas, as well as the College of American Pathologists template, they really break it down into 3 different regions. And so what we would consider, for instance, the head, body, tail, sometimes doesn't always coincide with what they think of. And so when they break it down into these 3 regions, there are really 2 specific lines that they draw whenever they're looking at any of these specimens. So the first is really to the left of the actual border of the superior mesenteric vein. So any lesion that is found over here to the right side of the leftmost border of the superior mesenteric vein is what they define as being the head. Between this left border or leftmost border of the superior mesenteric vein, as well as the left border of the aorta, they'd call the body. And then anything that is over on this side or to the left of the left border of the aorta is what they define as the tail. The uncinate is considered part of the head, and they oftentimes won't necessarily comment on it, depending on what the pathology groups are typically doing for their usual templates. And just as a brief refresher, if we go back to the anatomy and really the embryologic development of the pancreas, it arises from the foregut as far as the primitive gut tube. And as we recall, the pancreas itself really begins as 2 individual structures. The first is what we call the ventral pancreas, and this is really contiguous with the initial primordium of the biliary tract, as well as the dorsal pancreas. And then over the fifth week of gestation, the ventral pancreas rotates along the gut tube and eventually fuses with the dorsal pancreas. And when this all goes well, we have our typical anatomic normal pancreas as a result, where we have the major pancreas duct or duct of Wirsung, which joins into the major papilla. And then we have the minor or accessory duct of Santorini, which then joins into the minor papilla. And when we have failure of fusion of these two, so for instance, where the major duct of Wirsung only empties into the minor papilla, which is oftentimes inadequate, this is what we divide or what we call as pancreas divisum. And these patients oftentimes can develop, although not always, abdominal pain, episodes of recurrent pancreatitis, and sometimes even chronic pancreatitis. And so when we go into a bit more of the anatomic or an arterial anatomy of the pancreas, there are certain areas that everyone is very much familiar with, but we're going to dive into some of the more detailed arteries that we oftentimes don't necessarily think of. So begin with, if we go from the very top, kind of the first major branch off the abdominal aorta, not including the smaller ones, is the celiac trunk. This gives rise to three individual arteries, the left gastric, which goes up. We have our common hepatic, which goes to the patient's right side. And then we have the splenic artery, which obviously goes to the spleen. Now, some of the key arteries that come off of the splenic, if we spend a little bit more time on it, are several important name vessels that we oftentimes don't think of. The first is this large branch which comes down, which is known as the dorsal pancreatic artery. And its origin off of the beginning of the splenic can vary to some degree, but it's a major branch that comes down and then it divides into two branches, one that goes to the left and one that goes to the right. And these are known as the transverse pancreatic or the left and the right branches. And so, for instance, during the time of a Whipple, where we perform our transection along this retropancreatic tunnel along the SMV or the pleural vein, when we make this division, oftentimes we will encounter these branches of these transverse pancreatic or these dorsal pancreatic arteries. In certain situations, and I know oftentimes I do this, I put these hemostatic stitches across the superior as well as the inferior portions to help control it. If we go further down towards the body as well as the tail of the pancreas, the next major branch is this here, which is a large pancreatic artery or the pancreatic magna artery. And these all form this nice collateral anastomotic connection between all of them. And then finally, towards the tail, we have our caudal or kind of craniocaudal pancreatic artery. And so, as I mentioned, the transverse pancreatic is really important because we come across it during transection of the neck and even during the body and tail during the subtotal pancreatectomy. But when we think about chronic pancreatitis, we come across these vessels quite often when we perform coring procedures, especially of the body as well as the tail. Sometimes it can be the dorsal branch, sometimes it can be the large pancreatic, and even sometimes a caudal if it's taken all the way to that extreme. If we then follow the celiac and go back up, as I mentioned, we have the common hepatic, and then it goes down and branches off into the gastroduodenal. If we go upwards, this then branches into the left as well as the right hepatic arteries, the right hepatic typically giving off the cystic artery. Now, when we come back down from the common hepatic to the proper hepatic, and the GDA is a gastroduodenal artery as it comes down in front of the head and neck of the pancreas, there's another important branch that is oftentimes right next to it, and that is this little guy, which is the supraduodenal artery, also sometimes known as the artery of Wilkie. During a Whipple operation, when we're initially dissecting around this proximal portion of the GDA, it's really common to have to ligate the supraduodenal artery, otherwise you can run into some worrisome kind of nuisance of bleeding from that area. The GDA then comes down, it breaks down into the superior pancreaticoduodenal artery, and this then splits into two branches. One that's anterior, which is the anterior one, as this name implies, and one that's posterior. And these form a rich collateral network with branches from the inferior pancreaticoduodenal. And then the IPDA then comes into a common trunk and then joins into the superior mesenteric area, superior mesenteric artery. And so kind of taken together, you can form this nice big circular loop between branches off the celiac, which forms a nice collateral network or anastomotic network in the head and neck of the pancreas, and then joins with the SMA. And this is really valuable when we think about tumors that involve kind of the neck or the body of the tumor. So in this scenario, these tumors oftentimes arise within the neck and the body, as I mentioned, but because of their location, they ultimately involve some of the major vessels. This includes the splenic artery, which is over on this region. It can involve the common hepatic artery, and more often it can involve really the celiac trunk. And in situations where we have an involvement of all these structures, and even though it is involving the celiac trunk, as long as we see that there is a plane or a kind of an area off the origin of the celiac where it's free, we can do surgery to remove this tumor. And that's typically involves performing a near total, or basically a subtotal pancreatectomy, where we cut along the neck of the pancreas here. And then we also remove or divide the common hepatic artery, as well as the origin of the celiac. The splenic artery would also go as well. Now, the problem with ligating the common hepatic artery, as one might expect, is we really impact and affect the arterial inflow to the liver. Now, despite the fact that there is also the portal vein providing a lot of the actual flow to the liver, the hepatic arterial system is really important because it really provides the majority of the blood supply to the biliary tract, and we run the risk of causing biliary ischemia. However, that doesn't oftentimes happen in large part because of this collateral network, as I mentioned. And so really it's reliant on retrograde flow from the SMA down here. And so if we have good retrograde flow when we divide the common hepatic artery, it will come from the IPDA, or the inferior pancreaticoduodenal, in a kind of anastomosis along the superior or in the anterior. And then it goes up through the GDA, and then we can still get preserved flow. And so during imaging, it's important in these scenarios to not necessarily be able to see the anterior and the posterior pancreaticoduodenals, but really to look at the caliber as well as involvement of the gastroduodenum. If the tumor is involving the GDA artery, then we know that this operation may not necessarily be possible without actually doing some type of actual junk graft or reinstituting some type of connection between the aorta as well as the common hepatic artery. And this artery, or this operation, is what we call distal pancreatectomy with celiac axis resection, or a DP-CART procedure, or as commonly referred to as the modified Appleby procedure. And so if we take the arterial anatomy a little bit further away from the pancreas, but going up towards the liver, I'd already mentioned how the common hepatic kind of breaks down into the left and the right hepatic arteries as it goes up in this region. But it's also important to note that these branches also provide blood supply directly to the main common bile duct as well as the main common hepatic duct. And these are oftentimes located at the 3 and the 9 o'clock position. This was nicely shown in the paper by Northover and Terblanche, but they really did a nice corrosion cast analysis, and they really show where these arteries are in the rich capillary and anastomotic network that you can see that oftentimes we can't see even despite our wonderful 3 to 6 time powered loops. Now, there are key important parts of the arterial anatomy at this level that are really important to know when performing hepatobiliary and particularly performing pancreas operations, and really when we were talking about the Whipple procedure. And the first part of it is to really understand the relationship of the right hepatic artery relative to the common hepatic duct. And that is in that, does the right hepatic artery course anterior or posterior to the common hepatic duct? In the majority of time, typically about 80% of the time, we see that the right hepatic artery is actually behind the common hepatic duct. Now, this is important to know because oftentimes patients who come in with pancreas cancer will have jaundice and they undergo stenting preoperatively. This sometimes can result in inflammation or cholangitis, or worse yet, if they've had repeated bouts of cholangitis. When we use a right angle or a minimally invasive dissector and are trying to get in around the common hepatic or even the common bile duct, it can be a bit dangerous because we can inadvertently, especially if there's a lot of inflammation, cause injury to the right hepatic artery, especially when it's posterior. In the 20% of times when it's anterior, it can make it a little bit easier because it can be very easy to find. But it's also very important to note because when we are doing this biliary dissection, for instance, for a Whipple procedure, oftentimes we can be a little bit more expeditious when we're getting down to the porta and getting down to the bile duct because we know that we're going to be dividing it. However, if we know that the artery is anterior, we do need to take a step back and slow down so that we don't cause inadvertent injury to the actual right hepatic artery. The next more important part to know about with regards to hepatic arterial anatomy is the presence of an accessory or replaced anatomy. And what I mean by that is that having accessory or replaced either a right hepatic or a left hepatic artery. And this goes back as it's kind of a refresher to Michael's original classification, in which there was original 1953 and then ultimately revision in 1966 papers, really defined about these aberrant anatomies. And really the three of the 11 that he originally mentioned that we're going to be talking about is a replaced right hepatic artery, a replaced left hepatic artery, and a type 9 or a completely replaced common hepatic artery. Now, what that means is that a replaced artery is one in which, rather than having our typical proper hepatic come up into the left or the right, for a right hepatic artery, rather than it coming off of the proper hepatic, we see that it would actually come off the SMA over here and take a very unnatural course, or one that's not necessarily one that we would typically encounter. During the type 2 anatomy, where we have a replaced left hepatic artery, rather than it coming off the proper hepatic, it would come off the left gastric and take a bit more of a circuitous course. This is important to think about because if we look at where pars flaccida is, which is oftentimes in this area, which is that clear area between the inferior border of the liver as well as the lesser curve of the stomach, oftentimes we will open this area up and we can do it with relative ease. But it needs to be mentioned that during the course of an accessory or replaced left hepatic artery, you need to be a little bit careful because oftentimes that artery can be sitting there and we don't want to inadvertently divide it when we can avoid that. Now, with an accessory artery, not only do we have the typical proper hepatic giving rise to a left or a right, but in addition, we have another artery that comes off the either left gastric for an accessory left or comes off the SMA for an accessory right. And so just to provide a little bit of context and example, say we have a tumor and we in the head of the pancreas and we need to do a Whipple operation. If we end up having, or the patient ends up having a replaced right hepatic artery, because as I mentioned earlier, because it takes a slightly different course, this course isn't as medial as it usually would be during normal anatomy, but it tends to take more of this lateral course. And by nature of where the tumors are in the head of the pancreas, and by nature of where the replaced or accessory right hepatic artery is, it tends to take a course where oftentimes it gets involved with the tumor. And in these scenarios, we oftentimes end up having to do an arterial resection and reconstruction of the right hepatic artery, especially when there's not good collateral crosstalk within the liver itself. Now, let's just say that in a scenario where we're fortunate in that that replaced right hepatic artery actually is away from the tumor and we're not necessarily worried about it being involved, it's still important to know when this is present because, as I mentioned, this does take more of a very lateral course. And so in this scenario, for instance, when we're doing our biliary dissection for a Whipple operation, there's a really high chance of inadvertently coming into it because we oftentimes expect this lateral portion of the biliary tree where the gallbladder is to be free and be relatively away from important structures, particularly from the main hepatic arteries. But as you can imagine and see in this scenario, as well as, for instance, even unrelated to pancreas surgery, say we're doing a left gallbladder, if we know this patient has a replaced right hepatic artery, as you can see, say in a gallbladder scenario where we're having upward retraction of the fundus and we're dissecting along the infundibulum, we would expect this area to be clear because the vessel should be away. But as you can see in this scenario, this replaced right hepatic artery tends to be a bit closer and just need to be a little bit more cautious when doing this part of the dissection so we don't cause inadvertent injury. This is even more important in a type 9 anatomy where we have the entire common hepatic taking a very similar course. And so it's really important to mention and get used to at least seeing this so you can develop that kind of ease to which knowing that, yes, this is taking a normal anatomic course, or no, it tends to be a little bit more lateral and I should slow it down during that part of the operation. And so next we'll kind of jump into the pancreas venous anatomy or hepatobiliary venous anatomy. And generally speaking, as everyone's aware of, the portal vein, which sits up here, is really the formation of two structures, which is the splenic vein as well as the inferior mesenteric vein. The splenic vein then oftentimes gives rise to a few branches, and really the more notable one is the one down here, which is the inferior mesenteric vein. Now, this diagram comes from Gray's Anatomy, which is great, provides a very general overview. But the reality is it's a lot more complicated, especially when we think about hepatobiliary planning. And I would say that the venous anatomy is more, if as much or if not more important than the arterial anatomy, just because these tend to be a bit more nuanced and they can be a bit more problematic during pancreas surgery. And so the first branch we're going to talk about is the gastrocolic trunk, the trunk of Henle. Now, when we look at the inferior border of the pancreas, this is really that first branch that actually comes up under the actual pancreas. And this is really a gateway to the neck of the pancreas and really our access point to the superior mesenteric vein. So traditionally, even though venous anatomy can be very variant. There are three general branches we think of. The first is the right gastroepiploic vein, and this comes off and it goes upwards, and it goes to the basically the greater curve of the stomach, which would be sitting in kind of this region over here. If we kind of step away from pancreas surgery and we think about, for instance, doing esophagectomies, where we are using a gastric conduit, the gastroepiploic vein is extremely important because this is typically the primary outflow of the conduit itself. The other branches that come off of the trunk of Henle are a colic branch, which is oftentimes the superior right colic branch. And then we also have these branches which go to the uncinate or the inferior portion or the superior portion of the head of the pancreas. Oftentimes, this is the anterior superior pancreatic duodenal vein. And the reason, as I mentioned, why this is important is because it really provides direct access to the inferior pancreatic SMP. And without actually dividing this area, oftentimes it can be very, very hard, or we're at risk of causing a lot of damage to the superior mesenteric vein. Now, in scenarios, for instance, where we have tumors involving that head or at least the uncinate process, it can be really hard if there's a lot of inflammation or if the patient has had a cholangitis to get to this area or even to identify where it is. And so it can be used as a nice landmark. And the way I use this is if you look at the inset on the right, drawing as we get into the lesser sac, when you have the stomach elevated upward, it's very easy to find the right gastroepiploic because we know it is coming off of the trunk of Henle. So if you follow that from superior to inferior, and similarly, as you're dissecting and you have the colon retracted inferiorly, you can easily find the middle colics. And if you follow the path from the middle colic vein as it goes up, the path of the right gastroepiploic vein as it goes down, you can see exactly as it points to right where the neck of the pancreas or the infrapancreatic SMV will be. And so as we go along the inferior border, the next important venous branch to be aware of is inferior mesenteric vein. And the three things that are important to know are where exactly does it drain into. The most common location is oftentimes it can drain into the actual splenic vein. The next most common is it can drain into the actual superior mesenteric vein. And the third least common is where it can drain essentially into the crotch of the three. And the reason why this is important is in scenarios where we have a tumor that's involving the head, and we know that we're going to have to do a SMV/portal vein resection. In order for us to be able to do that, we oftentimes end up having to ligate the splenic vein. This allows a few things. One is if the tumor is actually involving the entire segment, we want to make sure that we get a completely negative margin. But similarly, if we know that if it's not involving it, dividing the splenic vein is important because it gives us a lot of extra length on the superior mesenteric vein, so much so that we can actually even do a primary anastomosis as opposed to having to do an interposition graft. But the challenge is if we ligate the splenic vein, oftentimes patients can be at risk of forming sinistral or left-sided hypertension because you have arterial inflow that's going into the spleen, but then you don't have outflow. And so in a scenario where you have the inferior mesenteric vein draining into the splenic vein, then you can actually get retrograde decompression because the splenic vein blood flow can go down and then back into the inferior mesenteric vein. In situations where you have it actually draining into the SMV, where that's going to be ligated, there's a slightly higher risk of forming sinistral hypertension. And in those scenarios, we sometimes think about actually plugging the splenic vein back into our connection or expecting some degree of a little bit of backup. Now, the next portion or vein that we talk about when we go along the superior border is a coronary vein or the left gastric vein. Much like the inferior mesenteric vein, this can provide decompression, particularly if we end up having to ligate the splenic vein. And it can go and drain into three different portions of the either splenic vein or the portal vein. The more common is where we see the coronary vein drain into the actual portal vein. The next most common is where we see it drain into the splenic vein. And the third is where it kind of drains somewhere in between in the actual crotch of the two. And as I mentioned, it's important because it can provide retrograde decompression of the splenic vein in the situations where we need to ligate it. But when we think about doing a total pancreatectomy, for instance, in that scenario, we're actually dividing almost every venous outflow to the stomach. And this can result in pretty substantial congestion because the short gastric veins are divided, the right and left gastroepiploic veins are divided in the right gastric vein. So really the main outflow of the majority of the body of the stomach really occurs through the coronary vein. And so if we do divide it, ultimately that subtotal portion or the kind of distal half of the stomach can get pretty congested and result in a lot of outflow or even delayed gastric emptying. And so sometimes if that is required because of inflammation or we don't have a choice or happens inadvertently, you oftentimes end up needing to do a near total gastrectomy just to reduce that congestion and sequela as a result of it. The other important thing I would note is during a Whipple operation, oftentimes our common hepatic artery lymph node tends to sit in this area. And if we know that the coronary vein drains into the portal vein, we can expect that, especially in the setting of a lot of inflammation, that vein is going to be sitting there and it is at risk of injury, or at least we should be aware that it's sitting there so that we can be a little bit careful or anticipate needing to ligate it in that scenario. As we go down a bit further, we run into kind of the more dangerous veins, and I would say that all of them are dangerous, but really this one kind of bothers me the most, which is the first jejunal vein. So it usually is at the origin, right where the trunk of Henle is, just inferior to it. And the course of it is really one of three. It can either drain posterior to the superior mesenteric artery, it can drain anterior to the superior mesenteric artery here or run anterior to it, or it can have a branch where it goes both in front and below. Now, this branch provides blood supply or outflow to the uncinate. And so when we have uncinate tumors, it can be really challenging because it can involve this first jejunal branch. So in the majority of times where it's posterior, if we have tumor that's involving it, it can actually cause inadvertent tears, or it can be very, very hard to get control because it's taking such a posterior course where we sometimes haven't begun this dissection to get between the SMA and the SMB. It can be hard to get into this area because of inflammation. And similarly, as we get down further deep into the root of the mesentery, this can be a very challenging location. Similarly, even if it isn't involved, but there's inflammation, as we're providing upward traction and then doing this dissection in this area, it really doesn't take much effort to cause a small tear along the first jejunal, and this can run posteriorly to the SMV, track along the SMV, and it can result in pretty substantial torrential bleeding. During this time, we really have to be careful because inadvertently putting stitches to try to control it, there are times where we can cause inadvertent damage to the SMA. And as everyone's aware, this can result in pretty catastrophic consequences if we ligate it or we narrow it substantially, resulting in a clot. And in 20% of the times where it's anterior, it can make it a bit easier, although not always, because these small little uncinate branches can typically be a nuisance if we inadvertently get into them. And then finally, as we go down into the distal branch, we have the jejunal and the ileal branch. And these are important to know for, again, uncinate tumors or with a lot of inflammation and extensive tumors where there is involvement. And there was a nice paper that came out from the Matt Katz and the MD Anderson group, where they talked about what to do in this scenario when you do have involvement. And they go on to nicely show that you can ligate either the jejunal or the ileal branch as long as there is a sufficient caliber. And they define it as having a diameter greater than 1.5 times the diameter of the SMA. And this is a nice way to show and to kind of do preoperative planning to know that can I divide the ileal or the jejunal branches if they're involved without having to do a reconstruction. And finally, the last little branch that can also be a nuisance is called the posterior superior pancreaticoduodenal vein, or known as the vein of Belcher. And so this comes into play because it is a fairly sizable vein that provides a lot of the outflow to the pancreas, particularly when we're doing a Whipple operation. So oftentimes when we think about doing kind of an inferior to superior or a caudal to cranial dissection in this region, usually we want to try to preserve this vein because once we've divided most of the blood supply or we've not quite gotten to the inferior pancreaticoduodenal artery, you can develop a lot of congestion of the head of the pancreas. And if you leave this vein intact, it allows or kind of prevents some of that nuisance of back bleeding that can develop. Similarly, as we're doing this superior dissection, you want to be careful that we don't do too much and inadvertently ligate or get into this vein because it can be pretty hard to access without getting good dissection above and below it. And so this was originally described by John Cameron, and these are coming from a lot of his trainees and really nice papers written about it as a vein of Belcher, because Belcher was apparently his first assistant, and he had described him as being short, fat, and always in the way. And so all of that really to say that typically when we look at preoperative imaging, particularly for pancreas and hepatobiliary, here's my kind of to-do list where we try to identify all the structures that we have gone through And it's really kind of in summary going through what is the arterial anatomy? Are there aberrant anatomies with regards to arterial, especially the replaced left or replaced right hepatic arteries? What is the relationship of the tumor in the head of the pancreas or body of the pancreas relative to these vessels? What is the venous relationship to these tumor itself? And then what is the venous anatomy? So really the course of the inferior mesenteric vein, coronary vein, first jejunal vein, and then finally, what is the course of the right hepatic artery? And so typically when we think about the easiest way as you're trying to learn this or being able to see this is to get what we consider a higher quality CT scan. And for this purpose, I'm using a CT as opposed to an MRI just for simplicity purposes. But what that means to me is really three different components. One is having a CT scan that has at least three different phases or at least two phases. The first is an arterial phase, and this occurs usually about 30 seconds after contrast is injected. The second is the pancreas venous phase, which occurs very shortly after. Sometimes the arterial and the pancreas phases are combined, but this is really to see enhancement of the pancreas before we see enhancement of the liver. So it's a very short interval. And then finally, the third or the delayed phase, which is a portal venous phase, where we can nicely see the portal venous, SMV, IMV all enhanced. The second component is to have thin slices. So slices less than 3 millimeters so that we can get really nice detailed anatomy. Typically, it would be nice to get 1 or 1.25 millimeter slices. And then finally, to not only have the axial, but then to also have the coronal and sagittal reformats. And to go through a scenario, we kind of go through a CT scan. So this is a patient that ends up having a pancreas head mass or pancreas head adenocarcinoma. And so first we'll kind of begin with an arterial phase. So as we come down, you can nicely see the dilated bile ducts. And kind of the way I approach this is I first find the celiac. So as we're coming down, the first major branch off of the abdominal aorta, as I mentioned, is the celiac, and you can see that right here. And I typically follow it by really following the splenic artery. So here you can see the splenic artery coming down. And I try to follow it and keep the mouse cursor all the way on it so I really don't miss it. Especially in a thin slice, you really won't follow it. So you can see it coming and you can see how you can easily get it confused with the splenic vein, which is right next to it. But you can see that it takes a very tortuous course as it's going into the spleen. You can imagine this is important when you're doing a subtotal or distal pancreatectomy at the course of this. And I'll note that the splenic artery is one of the two most tortuous arteries that are found in the body, in the abdomen at least. And so if we go back, we next go to the common hepatic artery. So if I go back again to the origin of the celiac, we can trace a branch and we can see this branch here. So again, celiac, and we can see this branch. If we follow it, we can see that it's coming up this way, going up into the liver, and we can see that it's kind of splitting and going into the liver. Now, it's a question of trying to determine, is this a left or right hepatic artery? And if I continue to follow it through, you can see that this branch primarily is going to this side, which is the right side of the liver. Here you can see the right portal vein. And just for reference, I'll say that Cantley's line, which is that kind of anatomical border between the left and the right liver, is right about here or so. So kind of the back of where the cava is to the gallbladder fossa, which is going to be over here. And so you can see this right here is what we can consider the left medial. And this is a left lateral segments of the liver. So we can see that this artery tends to go only to the right side, and I don't necessarily see a branch that's going to the left side. So that tells me that perhaps this patient may have a replaced left, but we're not necessarily sure. If we go back to the celiac once again, the way I tell our trainees to typically find the left gastric, which is a third more important branch, and if we have a replace where it would come off of, is to go back to the celiac. And rather than going down towards the feet, which is our common practice, I'd rather you want to go up towards the head because it takes a vertical course. So again, celiac, and if we go back towards the head, the only vessel you should see as you go towards the head, leaving my mouse cursor here, are two vessels. It's going to be the left gastric artery and the left gastric vein. And so if we continue to go back up towards the diaphragm, you'll see this branch, which is the left gastric. You can see it here course over to the stomach, as one might expect. And you can see as I follow it, it goes to the lesser curve of the stomach here. If we follow it back, you can see that it splits right here and it goes into the liver, into this structure here, which is known as the umbilical fissure. And so kind of as a similar way for our trainees, you can kind of think of this as kind of the backside or the buttock of the liver. You can see this little crack here, which is the backside of the umbilical fissure. And if you see a vessel going into fluid from the left gastric, it's either going to be a replaced or an accessory left hepatic artery. In this scenario, this shows that it's a replaced left hepatic artery. And within the umbilical fissure, you will always find not only a left hepatic, no matter if it's coming from a normal or a replaced location, but also the left portal vein as well as the left bile duct, which you can see nicely dilated, as well as one of the left portal vein. So next, if we go down from the common hepatic down to the SMA, you'll see this branch kind of coming right here. Oops, right here. I go down, and sometimes, depending on the arterial timing and the caliber of the actual artery itself, you can sometimes see an IPDA branch. On this one, you can see a tiny little incident branch kind of coming right here. But here I'm trying to determine that is there a branch coming from here going to the right side of the liver, which would be the course of, say, in this case, an accessory right hepatic artery. And I don't necessarily see that as we kind of come across it. And those are typically the most that I will find along the axial phase. Here you can see kind of as we come down distally, you can see a branch that's going into kind of the duodenum. And then as we go down further, you'll see the ileal branches as it goes into the jejunum. I then go and typically in a two-sided monitor, or at least having two images side by side, I would also have the coronal reformats. And I do the same, where in this scenario, I typically start off by finding the actual aorta. So I go all the way to the back where I can see the aorta. And then I find basically the two dots coming from the back of the screen to the front. And that's going to be your celiac, which is going to be right here, as well as your SMA right here. And here you can nicely see the left gastric artery going up. And as we know, this is a replaced anatomy, so you can see it kind of curve going into the backside of the umbilical fissure. And you can nicely see it go into the left side or provide blood to the left side. Similarly, if we go to the actual celiac itself, we can see that the celiac actually comes and then it goes down into the common hepatic. Here you can see the common hepatic kind of takes a bit more of a lateral course, even though it does come off of the actual main celiac trunk. So here you can see it takes a little bit more of a lateral course before it splits into the right hepatic artery. Now, what I didn't show from the axial was, of course, of the GDA. And that's if we go back to the celiac, you can see this early kind of takeoff, which is inferior on the lateral of the common hepatic. But then you can see that this, which is the branch of the GDA, kind of goes up. And then it goes down along the anterior portion of the pancreas. Here you can see the nice pancreas head and neck with a nice dilated pancreas duct itself. And so the final portion that I look at on the coronal is to look at the relationship of the right hepatic artery relative to the bile duct, as I mentioned. So here you can see a really nice dilated bile duct. And so the easiest way to find it, which I find is actually on the coronal as opposed to the axial, because the right hepatic can take a little bit of a tortuous course, the easiest way I kind of think of it is one is to find where the right hepatic artery. So here you can see the common hepatic. Here you can see it right there where it kind of crosses into the right hepatic. And so I leave my mouse cursor right here and I go all the way to the front of this patient. So here you can see all the way to the very, very front. And if I take it one slice at a time, leaving my mouse cursor where the right hepatic is, the question is, what do I see first? The bile duct, or do I see the artery? And here you can clearly see that the bile duct comes first. And then as we go further back, we can see anterior to posterior, the right hepatic artery. So this tells me that the right hepatic takes a posterior course relative to the bile duct. Next, as we go to the venous system, I tend to use the coronal phase because it makes it a little bit easier to see. And so as we go from front to back, we can see the portal vein. So we can see the right portal vein, left portal vein come together. We can see the SMB coming down here. We can see the splenic vein as it goes up here to the left. So the first branch we're going to find is going to be the inferior mesenteric vein. And so the easiest way to think of it is if you look at where midline is right here, there are really only two main venous structures that are going to run vertically in this direction to the left of the midline. And that's going to be your inferior mesenteric vein. And that's also going to be your actual gonadal vein because the gonadal drains into the left renal vein. So if I scroll relatively quickly, what is the first venous vertical structure we see to the left? And that's this guy right here. And so if we trace this up, we will see that it right here, we will see that it goes up and then it turns and it goes right here, which is basically right into the very proximal superior mesenteric vein. And just for relationship, you can see where the splenic vein is. So you can see it's going right into almost the crotch, but really very, very proximal superior mesenteric vein. Next, if we look at the coronary vein, you can see kind of this very large venous branch coming right here. And if we trace it, it's either going to go into the splenic vein or it's going to go into the portal vein. So if we continue to follow it, we can see that this venous branch right here is going all the way up into this area, and it's actually going into the portal vein and actually into that left portal vein as opposed to the main portal vein. The other venous structures, as I mentioned, are the trunk of Henle, and you can nicely see this. So just for reference, if you look right here, you will see the head of the pancreas. You can see the dilated bile duct. And if we look at the inferior border, you can see the SMV coming into view. And then you can see this early takeoff right underneath it. And this is your trunk of Henle, where you can see a branch going to the colon. You can see this branch, which is going to go up and go into the greater curve of the stomach, which is going to be a right gastroepiploic vein, which you can see it nicely here. And then you can see the small little uncinate branches, which are a little bit harder to tell on the coronal view. And then finally, if we go to the venous axial phase, I'm going to be looking at the relationship of the first jejunal vein relative to the SMA. So if we start up top, you can see the SMA right here. You can see the SMV right here. You can see the pancreas with the tumor right here. And as we go down, you can see that there's this trunk of Henle, just for axial reference. You can see it coming off right there. But you can see this very large first jejunal vein running posterior to the SMA. And this is kind of a nice shot of it. And you can just appreciate the caliber of this first jejunal vein relative to the SMV and SMA. And it's actually even wider in caliber than it is the SMV. And you can imagine that causing an injury in this area can be really, really hard and challenging to manage. And then finally, kind of the last shot is you can see the caliber of the jejunal and the ileal. And you can see that they're of outer caliber, and they're at least about 1.5 times the diameter of the SMA. So should we need to ligate one of the two, we would be able to do that. And so just taken together, based on this patient's imaging, we know that they have a replaced left hepatic artery. Even though the right hepatic has a normal anatomic coming off the common hepatic, it does have this lateral course, so we do need to be a little bit careful when doing that lateral biliary dissection. The tumor, which I didn't spend too much time on, was involving less than 180 degrees of the SMV, so anatomically resectable. The IMV drains into the very proximal SMV, sort of near the crotch. The coronary vein drains into the main and really the left portal vein. First jejunal is posterior. The jejunal and ileal veins are adequate in diameter, and then the right hepatic artery takes a posterior course. So initially, it seems very kind of tedious and kind of cumbersome to go through all this, but usually it only takes a few minutes once you get into the practice of doing this. And so with that, I know I've kind of gone over time, but I'd be happy to take any questions.
Thank you. Thank you very much, Samir. I hope you can hear me. I think there is a couple of questions we'll take now. So there's one question on the chat, which says, "What defines a positive margin versus negative vein involvement for cancer? Vein muscle involvement, or can there be a good amount of soft tissue around the vein?" What do you think? What would you take as a positive margin around the vein?
Whenever we do these operations, we oftentimes will send it for frozen section to get a sense of it. And typically, you can oftentimes see when there is substantial inflammation, or you can actually see kind of almost like this rind where you see the wall of the vein getting involved with the tumor itself. And in that scenario, oftentimes we know that doing a segmental resection is probably going to be of more importance than doing almost a side bite. Usually in those scenarios, it's when we try to do a side bite off the vein and we can see that may be involved. Otherwise, typically you can tell where the superior mesenteric vein is completely free from the tumor, both above and below. But usually histologically, we would send it for frozen section and then determine if do our tumor pathologists see actual tumor involving the vein. And typically that's usually within a millimeter or two. If I see that and I have the opportunity to take more, then typically I would end up taking more without causing too much morbidity. And oftentimes, if we do need to take that much, we usually do an interposition graft.
Sure. And the second question was, in this particular case, I think, is did you actually embolize the accessory right hepatic artery pre-op? I'm not sure, but yeah.
Yeah, we didn't. That is an option as well. So yes, very much so. When you don't have we're fortunate in that we have the ability to be able to do reconstruction. So in this scenario, the tumor itself was involving it. So I did end up having to, or actually in this scenario with the replaced left, we didn't necessarily have to do anything. The right hepatic artery was away, so we didn't necessarily need to do anything for it. But in a scenario, for instance, where you did have a replaced right or an accessory right, and let's just do the scenario of a replaced right going through the tumor. If you don't have the ability to resect and reconstruct, now I'll kind of take a step back and say that there are times where you don't need to reconstruct or replace right hepatic artery because there is sufficient crosstalk between the left and the right within the liver. Now, the times where that isn't the case is that if there's substantial inflammation, particularly in the porta, or they've had a prior surgery, sometimes there's so much inflammation that you can result in a lot of ischemia to the right side of biliary tract. And the easiest way to tell is to test clamp and use intraoperative Doppler to see that is there sufficient left to right flow, and you can measure waveforms and get really detailed to make sure you're not going to run into that problem. And if that is the case, then one is to resect that right hepatic and to do a reconstruction with either autologous vein or using kind of some native cadaveric tissue if that's available. The other is to do preoperative embolization, where you embolize that replaced right hepatic artery. You give the patient sufficient time to form collaterals in a robust network between the left and the right. And then at that point, during surgery, you can just do the resection and ligate the right hepatic artery, and then those patients will be fine.
I'm just going to take these two next questions as one, and then we'll probably move on to the next talk because we're running out of time. So, can first jejunal vein be sacrificed if involved in an uncinate mass? I think you touched on that subject already during the talk, and the answer was yes, so long as you get a fair amount of diameter on the SMV itself. And the second part of the question is, especially if the second jejunal vein has a common trunk that's involved. So, I think. We'll come to that. And then the other question is, do you dissect and ligate the IPDA first during a Whipple's procedure for less bleeding?
Yes, I'll start with the second one. So yes, we generally try to get the IPDA early just because it knocks out, at least there are other branches that go to the uncinate process, but if we can, we try to. It all very much depends on where the location of the tumor inflammation is. Sometimes it's just not possible to get to the IPDA early, and you have to work from the top side down until you get to the very end. And in those scenarios, oftentimes the vein of Belcher ends up getting ligated, and so you get a little bit of congestion. But it's really wherever the safe plane is. If possible, yes, kind of getting the IPDA early will help quite a bit with getting control of bleeding, although there can still be some. And as far as the second jejunal, it also kind of depends. Typically, with second jejunal, you usually will have first jejunal involvement as well. It can be done, and sometimes it does require kind of taking a little bit more of that duodenum or the jejunum on the other side of the ligament of Treitz, especially if there's a lot of congestion in that area. But typically, when it goes down to that level, it's really assessing and sometimes test clamping to get a sense of what parts of the bowel will get congested, because you'll find out pretty early.
Okay, thank you. And the last question I'm going to take is, do you do an SMA first approach for all Whipples? Is that your routine practice?
Yeah, great question. It usually depends. I wouldn't say it's a routine where we do SMA first, although for many scenarios, especially some of the more complicated ones, then oftentimes that is the case. And I think there was a really nice paper that came from Shailesh Strikande's group where he really kind of broken down into the various different approaches of getting to the and doing that dissection with SMA first being there. But it's a really nice dissection, and I think especially in a relatively straightforward Whipple operation, if you haven't done it, it's a really nice technique because the planes are completely free, where you can really get to and clear out the SMA. So during those times when it gets to be challenging, you're at least familiar with anatomy and kind of approaching it in that way. But it's a really nice dissection, and I think there's really nice videos out there about how to do it.
Yeah. Now, in interest of time, I'm going to move on, but I do have a quick question of my own. augmented reality during surgery. Gone through real intricate details about the vascular anatomy of the HPB system and pancreas in particular. Do you think there is going to be a role in the near future, or is there already for augmented reality to be a part of our surgical arsenal to be able to do dissections with overlapping CT scans to be able to map the anatomy correctly intraoperatively?
Yeah, I think it's already there. There are folks out there using augmented reality for exactly that. I do think it's definitely going to have a role. It will be there to help surgeons, but I think we also have to be realistic that, we need to kind of understand the fundamentals. And I think if you can get used to the habit of doing this with just straightforward cross-sectional imaging, and I think with many kind of programs and institutions, they have the ability to do 3D reconstructions of these so you can see it in a different manner until you get used to it. And then I think augmented reality intraoperatively will only assist the surgeon. But I think we still have to be careful in much with anything is that we don't want to be 100% reliant on it as well, because there are still errors that can happen. And I think just knowing when and where to look will still be of utmost priority and importance to the surgeon.
Thank you, Samira. I think that was a fantastic talk. Great intricate details of the anatomy and vascular supply in particular. And I'm sure everyone's learned a lot from that. Thank you very much again. Just we'll keep you on the line so that if we have any questions at the end, we might take them again. It's my pleasure now to introduce our next speaker, Professor Syed Ahmed. Many of you might know Professor Ahmed. He's the director of the University of Cincinnati Cancer Center and professor of surgery at the College of Medicine there. He's graduated from Duke University and then Maryland School of Medicine. He's done a cancer surgery fellowship at MD Anderson Cancer Center and joined as a faculty at UC in 2001. He's led the pancreas program in UC over 2 decades and has done significant work in surgery for chronic pancreatitis and auto-islet cell transplants and has completed over 300 such operations. He is going to tell us about surgical approaches for chronic pancreatitis, which can be a very debilitating condition in many instances. So it's my pleasure to welcome Professor Ahmed. Thanks, Syed.
Thank you, Harsh. First of all, I want to thank SFS and Dr. Shukla for really organizing these events. They're very valuable. I learned a lot from attending all these sessions. And today I'm going to talk to you about management of chronic pancreatitis. For the sake of time, I'm going to go through some of these a little bit quickly. And if you have questions, we can engage at the end. So we all know that chronic pancreatitis is really characterized by having permanent parenchymal destruction, which leads the patient to have persistent and recurrent abdominal pain and eventually endocrine and exocrine insufficiency. And pathologically, it's characterized by loss of acinar cells, fibrosis, stricturing, and calcifications. Now, these are some extreme cases of chronic pancreatitis. You can see a KUB on the left where you can actually see calcifications within the pancreas. Not often do you see the pancreas on a KUB. And then a coronal section here demonstrating calcifications in the head of the pancreas as well as the body and tail. And these are typical cases of advanced chronic pancreatitis. These are some imaging of MRCPs showing stricturing of the pancreatic duct. In ultrasound, there are endoscopic ultrasound guided principles of diagnosing chronic pancreatitis called the Rosemine criteria. And that becomes a lot more important when we talk about minimal change chronic pancreatitis, where the diagnosis is not straightforward. We know that in Western societies, the most common cause of pancreatitis is alcohol and smoking. And in fact, smoking is probably now the number one cause of chronic pancreatitis. There are two multi-center studies, the NAPS2 study in North America and the Italian multi-center study in Europe, demonstrating that smoking is equal to, if not exceeding, alcohol as a cause of chronic pancreatitis. And of course, other causes of chronic pancreatitis include gallstone disease, idiopathic genetic causes, including PRSS, which is an autosomal dominant mutation, oftentimes called hereditary pancreatitis. There are other causes, including congenital causes, hyperlipidemia, hypercalcemia, and uremia. Now, when patients are diagnosed with chronic pancreatitis, most of them undergo medical management. Of course, we want to be abstinent from alcohol if that's the cause of chronic pancreatitis, and oftentimes that leads to some relief of pain. Sometimes a subset of patients may benefit from enzyme replacement or use of octreotides, nerve blocks, but eventually most require management of their abdominal pain with narcotics. A subset may benefit from endoscopic therapies to dilate strictures or remove stents. And eventually, about 30 to 40% require surgical management. Now, what are the indications for surgery in patients with chronic pancreatitis? This is what I call the reasons we operate. The first and foremost are complications related to chronic pancreatitis, including obstruction of either the bile duct or the GI tract, pseudocyst formation, fistula, bleeding. Oftentimes, patients may have inflammatory masses in the pancreas, and it's hard to know whether that's related to chronic pancreatitis or cancer. So differentiation from cancer is the indication to operate. Recurrent acute pancreatitis, but the most common cause, over 70% of the time when we operate on chronic pancreatitis, it's from um, incapacitating pain that is refractory to medical management. So pain is the number one cause of why we operate on chronic pancreatitis. When we consider surgery, there are lots of factors that we evaluate, including the symptoms the patients are having, how much pain medicine they're using, whether or not they have endocrine or exocrine insufficiencies, history of surgery, the family history. But ultimately, we want to base the surgery we choose uh, based on anatomy. And what we want to know really are ductal and parenchymal anatomy. And we can get that information from a series of tests, CT scans, ERCPs, EUS, or MRCP. And every institution has their own style in terms of what they utilize to get this information. But really, when we're evaluating the patient and trying to determine what operation to choose, we want to really evaluate the ductal and parenchymal anatomy. And there are lots of different types of surgical procedures. There are resection procedures like the Whipple operation, subtotal or total pancreatectomy, and the Bager procedure, which is coring out the head of the pancreas. There are drainage procedures, the Pusteau, or what's now known as a Partington-Rochelle procedure, Isbicki, Duval. There are hybrid procedures, which include resection and drainage, listed here, the Frey, Byrne, and Hamburg modification. And then, of course, if they have cysts, we can drain the cyst into the stomach, the duodenum, or small bowel. We can also do things like sphincteroplasties and nerve interruption. So here's a case. This is a 62-year-old male with a history of alcohol use, known history of pancreatitis, who presents with 30-pound weight loss and abdominal pain that radiates to the back. And you can see on the CT scan, he's got a large inflammatory mass in the head of the pancreas. And this was biopsied and was not definitively cancer, but it really just showed atypical cells. And so this is when I was talking about inflammatory mass, this is a typical case where you don't know if that's related to pancreatitis or if that's an underlying cancer within the chronic pancreatitis. So based on that, we chose to do a Whipple operation, a pancreatic duodenectomy listed here, which again, to remind you, removes the entire duodenum, the head of the pancreas, bile duct, and gallbladder, and reconstructs with three anastomosis shown on the right, the pancreas, bile duct to the small bowel, followed by the stomach. Now, we've evaluated how effective a Whipple operation is for chronic pancreatitis, and you can see in terms of chronic pancreatitis and pain relief, it is quite effective, achieving pain relief in about 80% of individuals, and this is through multiple series that have been done over the years. So 80% is the number I quote to patients, and this is on long-term follow-up. Now, the surgeons in Europe, asked the question, why are we removing the duodenum and doing a lymphadenectomy for benign disease? is that necessary? And so they designed this operation called the Bager procedure, Hans Bager, a German surgeon, and it's indicated for patients with head dominant disease. It really kind of removes the head and leaves a small rim attached to the duodenum and bile duct, and then drains the left and right pancreas through a rouleau. And it's considered a smaller operation, perhaps less morbidity, but is equivalent to a Whipple in terms of achieving pain relief of about 80% at 5 years. So this is a schematic of the Bager operation where the neck is divided along the superior mesenteric vein. It is then rotated towards the duodenum, and the head of the pancreas is removed, but you're leaving a rim of pancreas along the C loop of the duodenum. If there is ductal obstruction from chronic pancreatitis, you can also access the bile duct and do a ductotomy at this point. And then you can take a rouleau and anastomosis both to the left pancreas as well as the rim of pancreas you leave along the C loop of the duodenum. And again, in this operation, you're not removing the duodenum, so you're not subject to the dumping syndromes and other sequelae from removing the duodenum. You're not doing a lymphadenectomy, and so it's considered a smaller operation than a Whipple procedure. Now, the next question that was asked is like, why do we have to go full thickness? Sometimes separating the SMV and the SMA from the back neck of the pancreas is quite difficult in patients with chronic pancreatitis and a lot of inflammation. And so this really cores out the head of the pancreas without dividing the posterior capsule of the pancreas. So it avoids potential morbidity of vein injury, and it avoids a second anastomosis. So you do a singular anastomosis to the cored out head, and data would suggest that perhaps there's less endocrine and exocrine dysfunction since you're removing less pancreas. And so here's a 63-year-old female with history of recurrent acute pancreatitis, current with persistent abdominal pain, frequent nausea and vomiting. And what we did in this scenario, as you can see, is that not only is there head predominant disease, but there's dilation and stricturing of the pancreatic duct. So the operation that's been designed for a patient like this is the Frey procedure, named after Charles Frey, who's an American surgeon. It avoids division of the pancreatic neck, allows drainage of the entire pancreas, removal of stones that may develop within the pancreatic duct. The entire space that's cored out is drained by a single limb, and it's similar outcomes to the Bager in terms of pain relief. So this is a schematic where you not only core out the head in similar to a burn procedure, but you also core out the ventral pancreas. Now, if you extend this and do a more extensive coring out of the ventral, that's what we call a Hamburg modification of the burn procedure. And again, that entire pancreas is then drained by singular rouleau of a small bowel. And then there's a case like this, which is not common, where you don't have a lot of parenchymal disease, but you have a dilated pancreatic duct. And this is where we do a Pusteau procedure or a lateral pancreatic jejunostomy. It's really indicated for patients with dilated pancreatic duct. We want to do a pancreatotomy of about 7 centimeters. That's most often associated with long-term palliation of pain. It allows you to extract all the calculi within the duct. It's a really straightforward operation with low operative risk and no decline in pancreatic function since you're not really coring out the pancreas or removing any pancreatic parenchyma. And long-term data would suggest that pain relief is achieved in 60 to 70% of patients. And so this is the typical Pusteau where you just perform a lateral pancreatic jejunostomy, again, about 7 centimeters. And so if you look at the long-term data of series that have looked at this, again, you can see pain relief is not as good as a Bager, burn, or Whipple, but can be achieved in about 50 to 60, sometimes 70% of these patients. We've looked at our own series at University of Cincinnati comparing a Whipple to duodenum preserving head resection. We looked at 59 patients undergoing a Whipple, comparing them to 22 undergoing a duodenal-sparing head resection. This was published almost 20 years ago now. And so our series has certainly gotten larger than this, but we had a median follow-up of 47 months, no difference in endocrine or exocrine function, no difference in pain. With regards to quality of life survey, were very similar. And for the patients undergoing duodenal preserving head resection, no biliary restenosis. There have been randomized trials looking at these operations. You can see here on this slide, comparing Whipple to a Bager, pylorus preserving Whipple to a Bager, Fry to a Bager. And you can see that all these operations are relatively equivalent at long-term follow-up. And the number, again, that I quote for most of the patients is that these operations, whether it's a Whipple or a duodenal sparing head resection, can achieve pain relief in about 80% of the time at long-term follow-up. Similarly, if you look at long-term follow-up, you can see comparing the Whipple to duodenal sparing head resection, that perhaps there's improvement in endocrine and exocrine function with the duodenal sparing head resection. Now, some series demonstrate difference, some don't. But again, the prevailing thought is that the duodenal sparing head resection will not cause the same exocrine and endocrine dysfunction as a Whipple procedure. So this is a large series, the Scopus prospective multi-center study that was recently published last year. This was a prospective trial evaluating surgery for chronic pancreatitis. This was performed in 22 centers, 13 countries, evaluating 207 patients. And the question here was, if we choose the surgery based on anatomy, both parenchymal and ductal anatomy, how effective are we in achieving pain relief? And the answer is 73%. So, the single institution studies and those smaller multi-center studies really were quite accurate. So if we choose the operation, whether it's a drainage procedure, a duodenal preserving head resection, or a formal pancreatic resection based on anatomy and parenchymal and ductal anatomy, you can see that palliating pain with the right operation can be achieved in over 70% of patients. Now, the other question people will argue is, why do we have to do surgery? Can we treat these endoscopically? And the answer is that surgery is more effective. There's been 3 randomized studies looking at the management of chronic pancreatitis, medical versus surgical. This is the very first prospective trial that was published in the New England Journal of Medicine in 2007. This was a study that randomized 19 patients to endoscopic treatment, 20 patients to surgical drainage, and you can see the surgery group had lower pain scales, improvement in quality of life outcomes, improvement in pain relief. The complications, length of stay, and pancreatic function were similar, and the endoscopic treatments required more procedures. Now, this is the most recent randomized study. This is the ESCAPE randomized clinical trial. This was published last year in JAMA. This is led by the Dutch group of 30 hospitals, and they really randomized patients to a step-up approach, which started with medical management, then stenting, then surgery, or early surgery. And this study reported 8-year outcomes. And again, what they found was that surgical management was superior in terms of improved pain score, decreased reinterventions, and a high proportion of patients achieving complete resolution of pain. Now, there are certainly some situations where the ductal and parenchymal anatomy doesn't allow us to determine what surgery to do. And these are the indications for when we don't have a clear approach of how we should manage these patients. And that's in patients with minimal change or small duct disease, those with genetic syndromes. Specifically, when we talk about genetic syndromes, the one we are most concerned about is PRSS, otherwise known as the cationic trypsinogen gene mutation. Again, autosomal dominant, also associated with long-term risk of cancer in 30 to 50% of patients. And there are some other, including SPINK, CFTR, chymotrypsinogen. There are other patients who've had previous operations, have benefit, now have recurrent pain, so people who failed prior surgery. And then those who have recurrent acute pancreatitis without a discernible cause, no stricture, no parenchymal disease, What do you do with these patients? So here's a good in um, um, framing the issue case. This is a 32-year-old female, 10-year history of recurrent acute pancreatitis. Over the past year, she has 1 to 2 episodes per month requiring hospitalization. Her enzymes are always above 1,000 in terms of amylase. She has baseline abdominal pain, which she rates 6 out of 7. She's now taking daily narcotics. And when you look at her CT scan, it looks like a normal pancreas. There's not calcifications, there's not duct dilation, there's no stricturing. However, when you do endoscopic ultrasound, you do see changes consistent with chronic pancreatitis, specifically lobularity, honeycomb lobularity. So she does have, based on Rosemine criteria, changes consistent with chronic pancreatitis. So what do you do here? Do we continue medical management? That hasn't worked. Do you do a subtotal resection? And if so, what do you do? Do you take out the left pancreas? Do you do a Whipple procedure? Or do you take out the entire pancreas? Now, there is an operation, the Isbicki procedure, that some people have proposed for patients like this, where you really just do a very large coring out procedure, a V-shaped excision of the ventral pancreas, and you drain it with a single rule-in. But really, if you look at management of minimal change or people with genetic syndromes, this is an ineffective procedure. Patients continue to have pain, and you haven't addressed the underlying cause. So at the University of Cincinnati, for this patient, we would do something called a total pancreatectomy with autologous islet cell transplantation, where we take the pancreas out, we take the pancreas to a lab, and we then take out all the islet cells from the pancreas. We purify the islet cells, and during the same procedure, we transplant the islet cells within the liver. And so if it works well, depending upon how many islet cells we get out, patients can be free of pain and not be diabetic. So it's indicated for people who've failed prior decompression or resection procedures, for minimal change pancreatitis, those with genetic syndromes, or those with recurrent acute pancreatitis. And we've done probably close to 400 of these operations over the last 2 decades. Again, this was our very first paper that we published. This was published in 2003 with our first 22 patients, 18-month follow-up. At that time, we demonstrated an insulin independence rate of 41% and a narcotic independence rate of 82%. So quite effective in managing these patients where there's really no other options. The goal of the operation is really fourfold. One is to improve pain. Two is improve quality of life. The third goal is stable glucose control. And really, when we talk about being apancreatic, we're talking about type 3C diabetes. Everyone knows about type 1 and type 2. Surgically induced diabetes is type 3C, where you also not only do you lose insulin, but you lose glucagon. So in these patients, if you take the pancreas out, they become hyperglycemic. You give insulin and they overreact to the insulin, they bottom out. And low blood sugar in these patients is what's dangerous. So by doing islet cell transplantation, we may not prevent insulin requirements, but we will prevent hypoglycemia and brittle diabetes. So that's a third goal. And the fourth goal is insulin independence. And again, that's only achieved about a third of the time, depending upon how many islets we can get out. So this is, again, a study looking at long-term outcomes after islet cell. This was a 5-year follow-up where we looked at insulin independence was maintained in about 27% of patients and narcotic independence in about 73% of patients. So even at 5 years, the operation remained effective. And again, you can see that there is a decline in insulin or exocrine. I'm sorry, there's a decline in endocrine function going from 38% to 27% from 1 to 5 years. And we've even looked at 10-year follow-up. You can see that narcotic independence remains at 76%. Insulin independence does go down over time. So some of the beta cells that are transplanted in the liver do decline over time. Quality of life, importantly, remains very high and in fact continues to improve. And this is kind of the algorithm that we utilize in managing patients with chronic pancreatitis. Really depending in the very beginning, trying to start with conservative management, and then based upon their anatomy and patient specifics, we decide what operation to do and when and if to use total pancreatectomy for the refractory cases or those with genetic syndromes. And I'll stop there. I know I went fast for the sake of time, but I wanted to get that in. Thank you.
Thank you. Thanks, Syed. Again, very in-depth talk on surgical management and approaches to surgery in chronic pancreatitis. I think it's a very debilitating and difficult condition to treat at times. So I think that provides significant insight into the surgical management. There is one question at the moment. So how do you deal with an undilated duct during surgery for chronic pancreatitis?
So good question. So again, it depends on the specifics. You can have again small duct disease and not have dilated ducts. And in that situation, that's when we do a total pancreatectomy. You can have calcifications in the pancreas and not have dilated ducts, and then do a formal anatomic resection of the calcified parenchyma. Um, or you can have diffuse calcification throughout the gland and not have a dilated duct, and you'd have to do a coring out procedure, but you can always access the duct. Typically, we would use intraoperative ultrasound to find the duct, to access the duct, and you can still do a lateral pancreatotomy. So again, the specifics really of the operation that you choose depends upon patient factors, but also parenchymal and ductal anatomy.
And there's a couple of questions on islet cell transplants. So in case of eventual IAT, do you remove the pancreas en bloc or Whipple and then a distal pancreatectomy? And how many islet per kilogram for complete insulin weaning post-op?
Yeah, good question. So again, depends upon what operations were done previously, but assuming the patient has the entire gland, we do remove it in segments. So we'll remove the left pancreas first, leaving the head vascularized with the GDA. So we don't want to make that ischemic. We then give the body and tail to our islet team who processes that in University of Wisconsin solution to prevent ischemia and warm ischemia time. And then while they're working on the body and tail, we take out the head. And by doing that, we minimize ischemia to the beta cells and allow them to work on them sequentially. Um, what was the other question?
How many islets per
Oh, right.
kg?
So based on our series, we look when we don't look at absolute islet numbers. We look at what we call islet equivalents, which is really an idealized size of islets based upon because islets, you don't want to make them free islets. You want to keep them clumped because when you make them free, they undergo apoptosis. And so we want to get about 6,000 islet equivalents per kilogram body weight. That's the number where patients may achieve insulin independence. 6,000 islet equivalents per kilogram of patient body weight.
Okay. I'm going to take questions from, I think, Ator as a combined question from them. So he's asking, do you do a pre-op workup for a dilated duct versus IPMN? And with islet cell transplantation, is there a level of endocrine insufficiency where you will not do it?
Yeah, very good question. So it's very important to distinguish dilated duct from chronic pancreatitis versus IPMN. And oftentimes that distinction is not difficult because IPMN will occur in the absence of calcifications or history of pancreatitis. But there are situations where the diagnosis is not clear. And in those situations, it's really based upon multiple factors to make that distinction. We can also do pancreas ductoscopy to evaluate the duct from the inside to see if there's any papillary growth within the pancreatic duct. But if there's any um, um, hesitation of what the diagnosis is, we always err on the side of safety. And so if there's any question about IPMN, we would do more of a resection procedure rather than a drainage procedure. If there is clear-cut diagnosis of pancreatitis, calcification, stones, then we would err on the side of doing more of a drainage procedure.
Yeah, and with islet cell transplant, is there a level of endocrine insufficiency
Right.
that you
So
wouldn't
another
do?
important
Yeah.
question. There was a time when if someone was on any insulin, we would not do islet transplantation, and we've changed that policy, mostly to make sure that they get counter-regulatory hormone. So the most important aspect of doing the islet cells is not really to provide beta cells to make insulin, but it's to provide glucagon to provide Brill diabetes. And so if someone's on less than 10 units of insulin, we will still do TPIAT to provide them the glucagon and prevent type 3C diabetes.
Okay. So I think in interest of time, I think these questions are from Chair, the same person. We'll take these as last questions. Do you measure C-peptide every day per stop? And then there's also asking if you do total pancreatectomy for IPMN of the main duct, and would you do an islet cell transplant in that situation?
Good
Um,
questions. Yeah.
yeah.
So we have a protocol where we definitely measure baseline C-peptide before the operation. We measure it again 1 month after the operation, then every 6 months thereafter for the first couple of years. We don't measure it post-op on a daily basis. You're not going to find any useful information. So we measure it 1 month after the surgery to see if beta cell function.
Okay.
And
And
for IPMN, yeah, so
yeah,
we don't do total pancreatectomy for IPMN. There is a group in Europe that has done this on a per call basis. I think it's very difficult to justify in my mind because if there's any invasive cancer within the IPMN, the way we isolate the islets is that we digest the pancreas in an enzyme called liberase. And if there's any cancer cells and we implant them in the liver, you're basically going to put the cancer in the liver. Now, there's never been a reported case of that happening, but theoretically, that's something that if it's done, it has to be done on a protocol because, I think it would be very not a good situation if the IPMN harbored some malignancy and then you transplanted that into the liver.
yeah. And again, a same person's question is, do you consider full molecular and genetic workup of pancreatic cancer before islet cell transplants? Risk of cancer post-transplantation.
So if they don't have cancer in their pancreas when we transplant them, because really, um, the if it's a if there aren't any transformed cells, because we do use an unpurified prep that we inject into the liver. So if there's not a transformed cell within that solution, there should be zero risk of cancer developing in the future. The only things that will survive are the endocrine cells. See, exocrine cells will not be transplanted. So if they don't have cancer at the time of the operation, then they're not going to develop future cancer based upon the transplantation. We do a genetic workup if the patient has a family history of recurrent acute pancreatitis. And if they do have family history of one of the autosomal dominant syndromes, then we would err towards the side of doing a TPIAT.
Okay. I think there's one last question. Patient with chronic calcific pancreatitis, CCT shows pancreatic duct of 12 millimeters with few stones in the duct, is having diabetes for 5 years but has no pain at all. Is there any need for surgical intervention, especially a pancreatic osteotomy for decompression?
Yeah, so this is a tough situation, and different surgeons will say different things, but I err on the side of doing surgery because if you leave someone with a dilated duct and chronic obstruction, they'll eventually get pancreatic atrophy and their diabetes will get worse. And so by relieving the obstruction, you'll prevent atrophy of the pancreas and perhaps prevent a further decline of their endocrine function. So I err on the side of doing surgery for that person.
Excellent. Thank you very much, Syed and Samir. I think very, very enlightening talks, and I've certainly learned a lot. Chronic pancreatitis, my practice is primarily more cancer-related practice, but we do deal with a few chronic pancreatitis patients once in a while. So thank you very much, both Samir and Syed, and I think we'll draw this session to a close. And thank you for all the audience for being there and listening patiently.
Thank you, Harsh. Appreciate it.
Thank you.
Went a little bit over, but I thought it went well.
I thought it went really well.
Yeah.
I think.
Yeah, sorry, it went a bit longer than expected.
No, it was worth it. It was such a great lecture. It was, every time you give that talk, I learn more. So
I was very detailed, and I think especially the checklist towards the end in terms of what to look for on the CT and how to go about making the preoperative decisions was excellent.
Yeah.
I think that's where we all need to spend some time to make preoperative decisions to make the operation run smoothly.
Yes.
Yep.
Apologies for interrupting you. We have to end the session. Is that fine?
Yes. I didn't hear what you said. Can you repeat that?
Yes. Apologies for interrupting you. We'll have to end the session.
Yeah.
Thank you. Bye-bye.
Thank you. See you.
Thank
Have
you.
a good
Bye.
weekend,
Have a
everyone.
nice day.